Welcome back to the IJGC Monthly Editor's Choice for July, where we will share with you highlights of our latest issue. Today, we're talking about some recent publications covering topics from the prognostic role of positive peritoneal cytology and isolated tumor cells and sentinel lymph nodes in endometrial cancer, as well as circulating tumor DNA as a promising biomarker for ovarian cancer. I'm Helena Obermair from Westmead Hospital in Sydney, Australia.
And I'm Friederike Stroisch from Heidelberg University Hospital in Heidelberg, Germany. We've got a fantastic lineup of articles today, all diving into some interesting areas in gynecologic oncology.
We're starting with the July lead article titled Rewinding the Clock on Positive Peritoneal Cytology in Endometrial Cancer. Does it predict prognosis in low-risk disease? By Diletta Fumagalli and colleagues from the Mayo Clinic.
This paper tackles a long-standing question in endometrial cancer. For those who might not be familiar, peritoneal cytology involves examining fluid from the abdominal cavity for cancer cells. Historically, if you had malignant cells there, what they called positive peritoneal cytology, it was considered a concerning feature. But it's a bit of a controversial topic because it was removed from the fecal staging system back in 2009. And the updated 2023 guidelines still state it's a finding of uncertain clinical relevance. So the big question is, does it really matter, especially for patients who are otherwise considered low risk?
The authors of this study really honed in on the relevance of positive cytology in this low-risk population who didn't receive adjuvant therapy. They used both the NCCN and ESGO guidelines to define two low-risk populations. These patients had endometrioid histology, grade 1 to 2, stage 1A disease, and the ESGO low-risk group also excluded patients with lymphovascular space invasion.
They found that positive peritoneal cytology was found in 8.1% of NCCN low-risk group and 7.9% of the ESGO low-risk group. Positive cytology was an independent predictor of recurrent disease, and patients with low-risk disease and positive peritoneal cytology had significantly worse 5-year recurrence-free survival compared to those with negative peritoneal cytology. For example, in the NCCN low-risk group, 5-year recurrence-free survival was 89.2% with positive cytology versus 95.9% without.
However, despite the higher recurrence rates, the authors observed no significant difference in overall survival between the patients with positive and negative peritoneal cytology. The 5-year overall survival rates were very similar across the groups. The study also notes that the overall risk of recurrence, even with positive peritoneal cytology, remained low.
So it can predict recurrences, but not necessarily overall survival in this low-risk group. This really highlights the complexity of prognostic factors. How do these findings influence practice or future research?
The authors suggest that these findings can inform post-operative counseling for patients. Knowing that positive peritoneal cytology is an independent predictor of recurrence, even if overall survival isn't impacted in the short term, could allow for more personalized discussions with patients about their individual risk profile. For future research, they emphasize the need to further investigate the role of peritoneal cytology in molecularly classified cohorts of endometrial cancer patients. This could provide additional clarity on its prognostic role, perhaps identifying specific subgroups where it might be more clinically significant.
It feels like we are constantly refining our understanding based on new data, even on things we thought we had settled. At our latest IJGC Journal Club, the authors from the Mayo Clinic discussed that they routinely collect peritoneal cytology for low-risk patients at their institution, because it's a procedure that involves low risk and low cost. If you want to listen to that recording of our Journal Club, you can check the IJGC website.
Let's move on to our first Editor's Choice article, which also touches on prognostic value in endometrial cancer, but from a different angle. This one is titled Prognostic Value of Isolated Tumor Cells in Sentinel Lymph Nodes in Low-Risk Endometrial Cancer, results from an international multi-institutional study by Giuseppe Guccinella and a large team of international collaborators also from the Mayo Clinic.
This paper really digs into the significance of isolated tumor cells, or ITCs, found in sentinel lymph nodes. For background, sentinel lymph nodes mapping is increasingly used in endometrial cancer staging as an alternative to full lymphadenectomy for the detection of nodal disease. ITCs are defined as clusters of cells less or equal to 0.2 millimeter. Just like peritoneal cytology, the presence of ITCs in sentinel lymph nodes does not change the FIGO stage. The question this study aimed to answer was the prognostic significance of these ITCs, particularly in low-risk patients who did not receive any adjuvant therapy.
They compared 42 patients with sentinel lymph node ITCs to 452 node-negative patients, all low risk, stage 1A endometrioid, grade 1 or 2 histology, and all without adjuvant therapy. Their findings mirror some of the complexities that we just discussed, finding that patients with sentinel lymph node ITCs had significantly worse recurrence-free survival compared to node-negative patients. This was true even after excluding patients with LBSI.
So again, a higher risk of recurrence. But was there a similar finding regarding overall survival?
Interestingly, just like with positive peritoneal cytology, the study found no significant difference in overall survival between the sentinel lymph node ITC patients and the node-negative patients. This is a key takeaway because it leaves open the question of whether adjuvant treatment is needed for this subset of patients, especially since the overall survival isn't impacted. The study also highlighted LVSI and FIGO grade 2 as significant risk factors for recurrence on univariate analysis.
That's really critical. It provides valuable data for counseling patients. One of this study major strengths is that it's a multi-institutional international study, and it includes the largest known cohort of untreated sentinel lymph node patients with low-risk disease. I'm going to repeat that sentence. One of the study major strengths is that it's a multi-institutional international study, and it includes the largest known cohort of untreated SLN ITC patients with low-risk disease. Plus, it's the first to exclusively compare SLN ITC patients with node-negative patients who had similar risk factors and treatment strategies. This level of focused comparison really adds clarity to the debate. However, it's important to note the limitations, like its retrospective nature, its relatively small sample size for the ITC group, and the fact that the node-negative patients were all from one center.
So both our July lead article and this editor's choice article point towards significant specific factors associated with risk of recurrence, but not necessarily overall survival in low-risk endometrial cancer, which is a nuanced but crucial distinction for patient management.
Exactly. And this leads us perfectly into our editor's choice article, which looks at a completely different but equally exciting area of cancer prognosis and monitoring, liquid biopsies. This article is titled Clinical Value of Circulating Tumor DNA for Patients with Epithelial Ovarian Cancer by Emily Loth and colleagues. It's a review article, so it synthesizes a lot of information. Helena, can you tell us about why circulating tumor DNA or ctDNA is such a hot topic in ovarian cancer right now?
Epithelial ovarian cancer is often called a silent killer because it's typically diagnosed at a late stage due to non-specific symptoms, leading to a poor prognosis and high mortality. Traditional monitoring relies on imaging and tumor markers such as CA125. But CA125 isn't specific to ovarian cancer, isn't effective for early screening, and its levels don't always correlate with prognosis. It also has a long half-life, making close monitoring difficult. This is where ctDNA, which is tumor-derived genetic material found in biological fluids like blood, comes in as a promising alternative. It offers quantitative evaluation of tumor burden, and it allows for qualitative analysis by detecting specific tumor DNA variations like genetic mutations or epigenetic modifications. Crucially, its half-life is less than 2 hours, enabling near real-time dynamic monitoring of tumor change, which is a significant advantage over CA125.
That short half-life really is a game changer for monitoring. The review covers several key areas to highlight. For screening and early diagnosis, ctDNA has potential, though high sensitivity and specificity are crucial to avoid unnecessary invasive procedures. Studies have explored specific methylation signatures for early detection with varying sensitivities. As a diagnostic tool, ctDNA levels correlate directly with tumor burden and disease stage, and it provides genetic insights into the tumor. For surveillance, ctDNA is a strong prognostic marker. Higher levels at diagnosis are linked to poorer overall and progression-free survival. It can provide earlier insights into chemotherapy response than CA-125, and it can also be used to detect microscopic residual disease after surgery and, very importantly, predict recurrences much earlier than CA-125 or imaging, sometimes by an average of 10 months.
Detecting recurrence 10 months ahead could be really important clinically. And predicting chemo resistance is another major area, right?
Absolutely. ctDNA can help anticipate resistance to therapies, such as detecting BRCA mutation revision, which is known to cause resistance to platinum-based treatments and PARP inhibitors. This ability to identify tumor-derived mutations and resistance mechanisms in the blood is incredibly powerful for guiding subsequent therapies and personalizing treatment.
Do the authors mention any specific hurdles to its widespread adoption?
Definitely. The review points out several challenges. Achieving the necessary high sensitivity and specificity for early detection in a low prevalence cancer is tough. The technologies used, like next-generation sequencing, can be expensive and require specialized infrastructure and expertise, although costs are decreasing. Digital PCR is more cost-effective, but is limited in the number of markers it can assess. Also, ctDNA levels and sequences vary significantly between patients and over time, making it hard to develop a universal signature. More research is needed to refine detection methods and establish its role in routine clinical practice.
So, a lot of potential, but also a lot of ongoing development needed. It's clear that liquid biopsies, particularly circulating tumor DNA, are poised to revolutionize how we manage ovarian cancer, moving towards more dynamic and personalized care. And when we look at all three articles today, there's a common thread: the drive to understand the individual patient risk beyond traditional staging, whether it's through microscopic cellular findings or molecular biomarkers like ctDNA. It's all about finding more precise ways to predict, monitor, and treat cancer.
What an interesting discussion based on these three articles. That's all for this episode of IJGC Conversations. Thanks for joining us, and we'll catch you next time.